Welcome all to our August edition of the TB Think Tank webinar series, which takes place on a monthly basis. This session is titled Urine TB Tests for Patients with HIV, an Expanding Diagnostics Landscape, and is presented by Dr. Bianca Sossen, who will be supported by Prof. Graham Mengies. So a brief introduction of our presenter today. She's a research medical officer and a Fogarty HIV-associated tuberculosis training program PhD fellow at the University of Cape Town. After her medical degree, she completed an MSc in the control of infectious diseases at the London School of Hygiene and Tropical Medicine. Since then, she has worked as both a clinical medical officer within the Department of Medicine and as a research medical officer, working on coordinating various observational studies and clinical trials with a focus on diagnostics for HIV/TB. So please all do engage, provide commentary under the Q&A tab, or raise your hand at the end of her presentation. Over to you, Dr. Sossen.
Thanks, Nolwazi. Just share my slides. Very grateful to have the opportunity to do this again after all the technical issues last week, and grateful that everyone's taken the time to join again. I'm hoping that you can now hear me and see the slides.
Yes, we
yeah,
can.
cool. Thanks for the feedback. So I'm going to be speaking, as mentioned, on urine TB tests for patients with HIV and kind of showing that it's an expanding diagnostics landscape. So we're all quite familiar with urine LAM, but going to take things a little bit beyond this as well. The background on where these tests come from is something that's likely very familiar to all of those in the audience, but ultimately the fact that TB is the leading cause of death and hospitalization in those with HIV, that there's a disproportionate amount of patients dying when they have TB and HIV compared to those that have TB alone, and that these patients often die before they get diagnosed or early on in the treatment course. So there's a very strong motivation to try and shift the entire diagnostics onto treatment timeline earlier so that we can get a rapid diagnosis and start life-saving treatment sooner than we currently are doing. And the reason why this is, can you, Nolwazi, confirm that you're just seeing the one slide currently? It looks very odd on my side.
We are seeing the third slide, motivation.
Thanks. So the main reason why we are trying to get these rapid tools is to save lives, but we're also trying non-sputum tests. Patients with HIV often present in unusual ways. They may present when they are unfortunately too unwell or have a decreased level of GCS and not be able to provide the sputum sample that we for many years have relied on. As you can see in the figure on the right from a paper that was done in India, we get the message, which we are all very familiar with as clinicians, that a lot more extrapulmonary TB happens in patients with HIV, and they may very well be overlap between those who have pulmonary TB and extrapulmonary TB, but the focus of diagnostics ultimately can't rely on sputum. And the figure on the left is a Venn diagram which was done from a large meta-analysis of thousands of patients, looking at how these patients get diagnosed within the first 2 days of coming to healthcare or a hospital. And because of the fact that sputum is such a difficult sample to get hold of, you'll end up having far fewer diagnoses actually coming from that test. So even though we know that Sputum Expert has a much better sensitivity than something like urine LAM, and the Sputum Expert manages only to diagnose around 61% of TB patients within 2 days, whereas comparing that to a urine lamb, which we know has a constrained diagnostic sensitivity, the amount of patients that you can diagnose rapidly approaches that at 41%. There, of course, is still a big gap, and that's why we're still working on things. But the message being that in these patients who are at high risk of dying, we need non-sputum-based tests that can rapidly make a diagnosis. There's a set of guidelines that have been released in the last 2 weeks by the WHO, focused on groups or companies that are designing these diagnostic tools, the target product profiles of non-sputum-based tests. So they've just been updated about 2 weeks ago. And a lot of that decisions around what kinds of tests we want came from a new modeling study that was done by FIND and the WHO. I'm not a modeler and don't find these results very easy to interpret, but the ultimate message that they're trying to give us is that when looking with a modeling approach at population level, and they used data from 3 different countries, South Africa, India, and Kenya, we can definitely allow for lower sensitivity if we have tests that can be performed in more patients, in tests that are easier to perform, and we will still likely be able to diagnose more patients that way. So that's where this is all coming from. So I'm going to spend time today speaking about urine lamb, some of the evidence behind this, the data from randomized trials, and then a few new lamb assays that are coming up. And then a little bit of time spent on DNA test or PCR tests, more specifically with regards to urine expert, which is, of course, the expert test that we're all very familiar with. So we know the diagnostic accuracy of Alere lamb or Aleph lamb from Abbott quite well. The Cochrane review was last updated in 2019. We know that the specificity of this test sits at around 90 to 95%. So we can be relatively confident that a positive is a true positive, but we will expect there to be about 5 to 10% false positives. With regards to the sensitivity, this does differ between whether we're looking at inpatients versus outpatients, those with low CD4 counts versus high CD4 counts. But in the kind of patients that are very sick, the inpatients, the sensitivity sits at around 50 to 60%. So while we can be confident in a positive test, we cannot use this test to rule out TB. There will still be a large group of patients who truly do have TB that are negative by Alere lamb. Despite its constraints in diagnostic accuracy, there's large randomized controlled trials which inform the guidelines on this tool, and we know that it can save lives when it's available to those hospitalized with HIV, particularly the very unwell ones. And it's a sort of 3 to 4% absolute gain in survival when this tool is available. So it's quite something for a diagnostic test to actually show survival benefit. It's not something that has really been shown in other tools. And this is really the data that informs why we aim to use this test very widely. I'm just going to spend a little bit of time focusing on the practical aspects of actually performing the LAM, presuming that there are healthcare workers or those actually performing the test on the call. It's important to ensure that we're using fresh urine samples, so not urine that's been sitting around for hours. It's important to read the result at 25 or up to 35 minutes. And it's important to use a reference card. And we know that in busy clinical settings, this is difficult to always adhere to. I know many clinicians that have never actually heard of there being a reference card. But it's very, very important because if we don't use the reference card, we're ultimately not sure of what diagnostic accuracy or whether we are actually going to get survival benefit based on our results when we're not following that guideline. So we know that with the latest version, there's 4 different grades that show up on the reference card. And in the patient area where there's a line that comes up if the test is positive, you compare that in the little, what I've highlighted in the red block, to at least being 1+ or more positive. Whether it's 1+ positive or 4+ positive, still means it's a positive test. It doesn't actually change how we act on that result. But I do kind of really believe that we should be at least documenting when we read the test, even if it's for the sake of kind of showing our colleagues that we've performed the test properly, and also to get a sense of the patient's kind of clinical pictures that come up at a 1+ versus a 4+, in the same way that you really have a sense of say, creatinine. You get a sense of how these tests perform differently. So the reference card being very important. We obviously have the issue that can be discussed about documentation of the results, seeing as we're performing this in clinical care, but it's important to have a system in place in your setting. We know that a positive test means that the patient should be treated, but we still need to enforce that we and support that we still do other tests to confirm things like drug sensitivities. And if it's a negative test, as I referred to earlier, this doesn't mean that the patient doesn't have TB. So again, it should lead us to test more. With all of this information, we know that LAM has been recommended more strongly as such since 2019 in specific sort of inpatients and outpatients. The inpatients is those with signs and symptoms of TB, those with advanced HIV disease, any seriously ill criteria, which is ultimately the abnormal vital sign, and CD4 counts less than 200. If we think of any patients coming into hospital, they are very likely to meet at least one of these criteria. So it essentially means that any hospitalized patients needs an allele LAM, and that it would be life-saving. In outpatients, there's certain subgroups. So in those with signs and symptoms of TB, in those meeting the seriously ill criteria, so abnormal vital signs, and then those with CD4 counts less than 100. Despite these sort of strong policy moves from the WHO, initially I think it was 2015, and then the update in 2019, there hasn't been that fast of a rollout of LF-LAM. There were initially some studies that looked into which high TB burden settings were actually using LAM, and it was not very, very good. This is a recent study that looked at throughout sub-Saharan Africa, at least which countries in green on the top map, which countries actually have a LAM policy locally at all. And then you can see further down those that are kind of confirming that they are regularly and using LAM throughout their country. And so it's not perfectly rolled out in all settings by any means. There's also a lot of research that has gone into looking sort of in real world settings. How does this actually translate into clinical care outside of a research setting? And there's various studies that have shown things in different directions, but I'm just highlighting one here in particular, was a study in Ghana. Of those, in the various sort of box plots of those eligible for LAM testing, only a proportion actually had the LAM performed, 93%. 41 of the cases were LAM positive, but only about half of those, despite being LAM positive, got started on TB treatment. So there's clearly a sort of practical real-world gap that's still happening, and which, we need to try reinforce, connecting patients who get this test and who are positive with the treatment that's due to save lives. What I also wanted to share is that there is a lot of excitement into new LAM assays that are being developed. We had a very sort of exciting few years being involved in studies to do with the Fuji LAM assay, which is in the top row. It showed very exciting gains in sensitivity and similar specificity compared to allele LAM. But when it was studied thereafter in large prospective bedside tests, it unfortunately showed some lot-to-lot variation. So there were manufacturing issues with that particular test. But the developer, or the manufacturer at least, is talking about a next generation version. So that would potentially come up if the data comes through. But there's multiple other companies that are working on different LAM assays that generally are performed at the bedside, some actually on sputum, others generally on urine. And so there's a lot of excitement in this field. This list, also just to specify, is very much not an exhaustive list. I wanted to kind of now transition from LAM over to the new assays and kind of highlight just 2 clinical cases that I highlight the kind of gaps that are ongoing in this area. So we recently had a 27-year-old lady newly diagnosed with advanced HIV. CD4 count was 28. She came in complaining of TB symptoms, generalized weakness, and she was noted to have severe anemia. She was unable to produce a sputum sample at all. Her urine LAM was positive, and so she was started on TB treatment, and that same weekend discharged home. So, I mean, this is probably happening a lot and should be happening. But one of the kind of key gaps that went on in this case was that she never actually had confirmation of her drug sensitivities. She luckily was sort of involved in one of our research studies, and she had a urine expert ultra, which came out on the Monday morning, by which point she was already gone home, discharged from hospital, which confirmed rifampicin resistance. So it's an important reminder, this particular case, to do what you can to kind of confirm drug sensitivities, which is something that we know, and just kind of using this as a transition into our next topic. Another potential way that the story can go, so a 29-year-old lady, advanced HIV again with a CD4 count of 34. She was admitted with TB symptoms and abdominal distension. Unfortunately, this was on a long weekend, so a lot of services within the hospital weren't functioning. She was again unable to produce sputum. Her urine LAM was done, but was negative. And ultimately, she had to kind of wait a few days for the inpatient team for the radiology team to do her abdominal ultrasound once it was a weekday. But by day 5, after the long weekend, she had already developed septic shock. She had a venous lactate of 7, worsened kidney injury, and possible DRC. And ultimately, this is precisely the kind of patient who we heard in the beginning are the ones who are dying, and they're dying without a diagnosis and dying early on. She also had the opportunity to take part in a research study which gave access to Urine Expert Ultra, and her TB diagnosis was confirmed, and she initiated treatment. So, as mentioned, I was using kind of 2 of the clinical cases to transition into the next part of the talk. Urine Expert Ultra is not something that we are able to perform routinely in the clinical service in South Africa. It is something that very recently the WHO included in a policy brief titled Identifying Common Opportunistic Infections Among People with Advanced HIV Disease. And it's specifically mentioned as a potential tool that can be used in extrapulmonary TB. We've known for almost 10 years now that this is a potentially useful test. This is a study that was done by Steve Lawn and published in 2015 already, using the older Urine Expert MTB RIF cartridge, so not yet the Ultra. And the important finding in the study was in those patients admitted to hospital with HIV, irrespective of their reason for coming to hospital, they all had TB testing done. Almost 100% of them could produce urine within the first 24 hours of their admission, whereas only 37% could produce sputum within that same time. And as a result, the Urine Expert actually had a remarkably higher diagnostic yield compared to a sputum expert. So the diagnostic yield in that study was 64% compared to sputum, which was 28%. When using those tests together, went up to about 78% could have their diagnosis. It was also the first study that showed us that there was a benefit in concentrating the urine before running a Urine Expert test. So the actual kind of lab factors behind this, it's the exact same tool. It's the Expert Ultra we use just as we do on sputum. You use a fairly large volume of urine, ideally. So the studies have generally done anywhere between 15 and 30 mils of urine. This gets concentrated at very high revolutions and then kind of re-added to either urine or saline with the expert buffer, and the test is run. So it does have a few more steps involved compared to sputum, but it's very simple steps, just ultimately the centrifuging. A few studies have started popping up on the Ultra cartridge. So as the previous literature that I'd mentioned was using urine, but on the expert, the older version, now looking at Ultra. In a study done, I think this one was in Ghana, in just patients that are outpatients with pulmonary TB, they didn't report on diagnostic yield, but they did report that there was a kind of sensitivity gain of about double for Urine Expert Ultra. Just remembering that we do expect a low sensitivity in outpatients, ambulatory patients with pulmonary TB. In extrapulmonary TB, a study from Tanzania, overall, as you can see from the various Euler plot rings, Urine Expert Ultra, despite in this study the fact that they had extensive testing with sputum and tapping all sorts of effusions and sending off anything that they could, there were still some patients who could only be diagnosed on the Urine Ultra, and that was around 7% of their TB patients. And then there've also been some literature looking in more selected groups. So, of course, we would expect in genitourinary TB that Ultra would do well. So in this one particular study, there was a sensitivity of 100% and a specificity of 100%. But then there have also been some that have looked in other sort of selected extrapulmonary groups. So in patients with TB meningitis and then TB lymphadenitis. So the particular kind of use case for these that the authors motivate for is, for example, in a patient where you're suspecting TB lymphadenitis, but perhaps the FNA isn't possible or is temporarily sort of contraindicated in your particular patient, a Urine Expert Ultra is a potential other test that you could consider. What we've also done is kind of broaden our approach and look in unselected cases. So, of course, we know that when a patient presents to hospital with HIV or to an outpatient clinic, they don't come up front telling you that they have TB in their lymph nodes or in their genitourinary system. They come complaining of general sort of TB symptoms and may have localized disease on top of that. So in an unselected approach, so 3 different cohort studies that we've had a look at. One was done by Dave Stead, cohort number C, based in East London. And then the other 2, I've been involved in the sort of local sites. So cohort A is a multinational study performed in 7 different countries. But one of them was, one of the sites of that study was Mitchell's Plain Hospital in the Western Cape. And then cohort B conducted in Butterworth in the Eastern Cape. So besides for these being sort of large cohorts, more than 2,000 patients, we can also be reassured that a lot of this data comes from locally. As you can kind of see from the descriptives or the demographics of these various cohorts, they all are quite different. So cohort A included some outpatients, whereas cohort B and C was only inpatients, various different levels of ART coverage and median CD4 counts. So the message ultimately overall being that cohort C is the sickest of the 3 and cohort B a little bit more well and cohort A the sort of more well of all of the 3 cohorts. The one aspect that cohort A can particularly report on, because it was particularly designed to be a diagnostic accuracy study, is the sensitivity and specificity of this test. And this is, again, just to re-emphasize in all comers who come to a hospital or a clinic. And we saw that the sensitivity was similar to LAM in this particular cohort, but had much improved specificity and positive predictive value. So you could be more confident that a positive test was truly caused by TB when compared to LAM. When looking now at diagnostic yield across these 3 cohorts, and this now we're kind of emphasizing in all possible TB patients, which ones could be diagnosed by either of these rapid tests. Sputum Expert Ultra could diagnose 55% of them, whereas Urine Expert Ultra could diagnose 53%. So it really does put in kind of quite a bit of, does very well, as in addition to both sputum and LAM. And if you had all three of these tests potentially available and conducted in these patients presenting for TB workup, you would be able to have a rapid diagnosis just from these three tests in 85% of your TB patients. One other aspect to kind of hone in on with regards to the diagnostic accuracy is that I think that this particular tool, talking about Urine Expert Ultra, is going to be particularly helpful if it were to be an option in patients with TB bloodstream infection or bacteremia. And we know from previous literature that these are the cases which have a very high risk of dying. They die early, and particularly more so if treatment is delayed by as little even as 4 days. We know that ultimately bloodstream infection is confirmed by a backtake, by a TB blood culture, and that's something that takes weeks otherwise to give us a result. So across all three of these cohorts, there were subgroups who had confirmed TB bloodstream infection, and in all of them, Urine Expert Ultra was kind of the most likely test to be positive, anywhere between 79 and 86% of those bacteremic patients. Sputum Expert didn't really do too well, anywhere between 21 and 50%, and LAM ranged from 59 to 68%. So this is potentially the group of patients, those with bacteremia or disseminated TB, who are going to potentially reap the most benefit. One other additional aspect that Urine Expert Ultra, of course, can give us is a rifampicin read. We know that LAM in its current form can't confirm whether we're dealing with rifampicin resistance or sensitivity, and that's just an inherent aspect of that tool. But Urine Expert Ultra has the potential to kind of give us a very useful additional result in addition to just confirming TB, in that it can look at rifampicin resistance. So across these three cohorts, in cohort A and cohort C, there were no cases of rifampicin discrepant calls between the Urine Expert and the other tests. In cohort B, there were 3 cases where rifampicin resistance was called on urine, but the other tests were calling rifampicin sensitive. So overall, it's only 8.8% discrepant calls that were being seen. This is potentially sort of heteroresistance that could have been happening in those clinical cases. And we think that ultimately, when having a rifampicin resistant call, you may kind of consider whether what all the other tests have shown in that patient. But this is a very useful additional result that you get from this test. We've also had a look at Urine Expert Ultra and its association with mortality. So in cohort A here, I'm not sure, it's not particularly showing up very well, these figures, for some reason, but the message being ultimately that when adjusting for other aspects, such as ART status and CD4 count, there is an association between having a Urine Expert positive result and mortality. And so we don't yet know, like we do with LAM, whether having access to Urine Expert Ultra gives a survival benefit, but we have seen, as I'm showing you here, that there is an association between having a positive test and being at a higher risk of dying. So it's identifying those patients that potentially would have a great advantage from having treatment initiated earlier. And the same message sort of comes through with the disseminated TB and bacteremic patients. I'm not going to spend too much time talking about other sort of DNA methods. There's a few years ago was a lot of excitement into this new potential methodology of cell-free DNA, which my understanding is we took from kind of oncology and fetal medicine fields. What has been shown is that there's potential, this is potentially sort of an exciting field, but there's a huge variety in diagnostic accuracy that's being seen from the various different tools or assays that have been designed in this respect. Various groups are still working on sort of optimizing these methods, but for now, it's not something that is scalable at all. There are, of course, other nucleic or NAT platforms that are coming up. So while we've got a lot of data and exciting data on Urine Expert, we don't yet know how that would perform in the other NAT platforms, but are hoping that sort of new results will come through and that they will be just as reassuring. So some sort of take-home messages. This is not meant to be kind of a bashing of sputum. And it's important that we still send sputum whenever we can in these patients. That allele-LAM or the Aleph-LAM is important to be used in all hospitalized cases or in certain outpatients, as we'd gone over. That it's important to conduct this as per manufacturer's guidelines, so making sure you're using the reference card. If you get a positive result by LAM, to make sure you're still testing more to look into rifampicin sensitivities. If you get a negative result, that we can't trust that that patient doesn't have TB, so again, to test more. We're hoping that Urine Expert Ultra might be something that could be sort of considered more widely or outside of research settings, potentially in inpatients, particularly when they can't produce sputum, and that will hopefully be able to save lives while we are waiting for all the other exciting new LAM and other assays that are coming out. But ultimately, we still need more affordable, rapid, non-sputum tests to take this all forward. That went a little bit faster than expected, but thanks. I'm looking forward to discussing. Many people involved. Olwazi, are you?
Yes, I am still here. Thank you
Okay.
so much, Bianca, for your presentation. Colleagues, it is now time for our Q&A session. So please do raise your hand to ask a question. Okay, Saloma, I can see you. You may go ahead.
Okay, let me ask. Hi, Bianca. Thanks very much. Really nice presentation and makes such a strong point about using all the tests that we currently have as we're waiting for newer tests and better tests. We have some to our disposal. I was just wondering, and probably this question isn't directly to you, but how easy, you said something about it's not available. So does that mean that the labs are not actually doing urine experts? And I don't know if anyone from the lab services could tell us whether it is available in some labs or whether it's going to be easy to make it available. And maybe if there's no one on the call or if you can't answer, we can take it up as the think tank and go and inquire with our lab partners.
Yeah, so currently in a clinical setting outside of research, it's only, at least where I'm based, it's only performed on a case-by-case basis after discussion with sort of specialist level, either microbiology or ID, but they won't allow for it to be done outside of that. We have been trying to engage with some colleagues within the NHLS and otherwise, which I'm sure Graham can also add on about. But yeah, it's been a slow discussion thus far. We're hoping it will be taken forward fairly soon.
Yeah, Bianca, should I just step in and add to that? Yeah, so it's not currently part of national guidelines in the testing for TB, and it's not routinely available. Certain labs offer it by special request. As Bianca said, we have raised this with colleagues at the NHLS Shahid and colleagues, and they are looking into it. I think some of the the issues are: is there a need for more data? Bianca's shown you all of the data that currently exists, and there might be a question as to whether we need further studies to show what its role is. Then there's obviously costing issues. If it was widely available, that would add significant costs to the lab bill. And then there's capacity issues at labs, and particularly as labs are potentially transitioning to different PCR platforms. This is, with the current evidence, it only exists for the Expert Ultra cartridge, and it might not be have similar performance with some of the other PCR-based platforms. So there are a number of issues, but we strongly motivating that it be considered in the first instance for inpatients, and inpatients, particularly those who are unable to produce a sputum sample, and those patients, as the data that Bianca has shown you, that it performs as probably the best diagnostic test in that group of patients. And we've also raised this within the think tank, within the treatment subgroup, and Bianca put together a policy brief. So that's also going forward. And as I said, I think it is a complex issue. It's not a straightforward thing. There are a lot of considerations, but one of the reasons for Bianca presenting it here today was to really just ensure that everybody's aware of these issues, and potentially would be supportive of the motivation to have it introduced at least for a select group of inpatients where it can expedite the diagnosis. Thanks.
Thank you so much, Prof. Violet, you may go ahead. Violet? You're unmuted. I have unmuted.
Thanks.
Yes.
Thanks. Thanks a lot, Bianca. I was struggling to figure out how to unmute myself. But thanks a lot, Bianca. I just wanted to clarify, I might have missed this. This was a really great presentation. So you had the cohort B that had discrepant results between the expert and the urine lamb. And I was just wondering whether you explored those, whether you explored those further just to understand the discrepant DST results.
So
Cohort B, yeah.
Yeah. So I think potentially what we've highlighting there is the discrepancy between the urine expert and sort of all other available tests. So whether it's sputum expert or sputum culture or blood culture, whatever came up. As we'd kind of highlighted, it's only 0.8% over the entire group, and some of that may actually be hetero-resistant in the patient. But beyond that, it's kind of something just to remember as a flag, I think, in your mind, but still provides, I think, very valuable data in the majority of the patients.
Absolutely. No, I just wondered if there was, whether you looked at, say mutations, just to understand that more. But I think absolutely, it's low levels of discrepancy. Thanks a lot, Bianca.
Thanks for the question.
Thank you. Tom, you may go ahead. Tom, can you hear us?
I'm not sure if Tom wanted to mention the comment that he made in the chat. If there was something.
Perhaps in the meantime, are you able
Tom's
to address his
unmuted.
comments?
He's probably having trouble unmuting himself.
I did unmute him.
Okay, sorry. Hello. Sorry, I've worked out how to do it. Sorry. No, it wasn't the comment in the chat, although I think that is slightly important, that it's common for people to come running down the corridor with these urine lambs, which have got a very, very faint line on. which in the old, if ever people remember, the old reference card was called 1+, but now it's not on the reference card, and that is actually negative. It doesn't mean the patient doesn't have TB, of course, but it is LAM negative if it doesn't reach the 1+ line. But that wasn't what I wanted to say, actually. I think the work on the urine expert is fantastic, and certainly would very much like to have that at our disposal widely for these inpatients. It's really superb. The issue I wanted to raise sort of for discussion is that there's the specificity of these non-nucleic acid tests in the urine, the LAM, and then it seems pretty clear that as LAM tests get more sensitive, they get less specific. And we've got a number of known reasons for that, probably some unknown reasons. And when the Fuji LAM first came out, it was statistically it wasn't less specific, but actually it was quite a lot less specific. It didn't meet statistical thresholds, but actually it's quite a lot less specific. And it seems that as they get more sensitive, that's what happens. And there's at least two reasons for that. One is non-tuberculous mycobacteria, which has been well described, Jeremy Nell, I think, first. And also we've increasingly been seeing nocardia patients who are LAM positive, and we can't find TB anywhere. And we heard of a child who died of nocardia because they kept being treated for TB and nobody could find the TB, and then they died, and it was all based on the LAM. So I just wanted to raise that issue. I think it's quite important, and it's going to get more important as they get more sensitive, I think, probably to the point that they're going to become less useful. So I think we might probably have reached the sweet spot with LAM. River.
Yeah, agreed. Important aspect.
Yeah, Bianca, can I just add something in response to Tom's point in the chat? I mean, I think this is absolutely critical, and the big issue that is of concern to me is that LAM is being used across our health system, and particularly in a hospital level where there hasn't been adequate training on the use of the assay, and often people, junior doctors are just getting access to the assay and haven't been trained on its proper performance. As you said, they might not even be aware of the reading card, or they don't have access to the reading card. And, there's lack of quality control and quality assurance. And that's really problematic for a test that means putting a person on 6 months of TB treatment. When it's not performed according to manufacturing instructions, you're going to get an increased rate of false positives. And there's this common misconception that a faint line is trace, or it could be TB, or and there's not the rigor applied that was applied in the studies, that a positive test is only 1+ or greater, and that if it's a fainter line that's negative, doesn't mean that it's not TB, as Tom says. It doesn't mean you can't repeat the test, and the national guidelines do allow for that. A repeat test suggests possibly an early morning test. But it really should be emphasized that it needs to be done according to manufacturing instructions, and only a 1+ or greater is positive, and that's not happening in our services, and it's a cause of concern that a test is being used in a way that all of the data that we have available doesn't support its use in that way. So, I think that's something that the think tank could do, is to just alert the clinic, the department, and the clinical services to really the need to perform it according to manufacturer's instructions. Thanks.
Thank you, Prof. Pren, Pren, you may go ahead.
Thanks, Bianca, for a great presentation. I just wanted to pick up on Graham's comment around the use of urine ultra in patients who can't produce sputum. Your results on the increased sensitivity from all 3 tests suggests that there should be some sequential use of all 3 tests, potentially starting with the bedside one, which would be the urine LAM, and then going on to potentially the other 2 in parallel. If you look at this from public health perspective, we really haven't made any impact on mortality in South Africa, TB mortality, for many years. I do think that cost considerations shouldn't be the key factor that kind of prevent an optimal algorithm, bearing in mind that hospitalization costs are much, much higher than the cost of doing both of those tests in parallel. I just wanted to get your thoughts on that.
I'm not sure if the question was posed to Graham or myself, but I would definitely agree. I'm just, you kind of have to figure out, how things would work logistically if performing them in parallel, was trying to kind of save on potentially duplicate results being positive, but we haven't kind of studied this test as within an algorithm. It's kind of just diagnostic accuracy studies performing alongside each other. But I definitely agree with the part about focusing on saving lives rather than cost. But I guess in reality, a lot of the policymakers will want to have data on that.
Yeah, Brenna, I certainly strongly motivate for the test. Just saying that, the costing implications are a consideration. But I think once one factors in the potential for this to expedite diagnoses and reduce mortality, although that hasn't been demonstrated in trials like LAM, I think it's a strong argument can be made, and I think we should make that. I mean, the other thing to consider when one's considering costs is if we're only using it where patients can't produce a sputum in hospital, then in terms of costs, you're actually saying that you're providing one expert test per patient. So it doesn't actually end up being more costs because you're still using only one expert per patient. If you can produce a sputum, you do the expert on that. And if you can't produce a sputum, then you do the expert on the urine, and it's still one expert per patient. And I think some of what we need to look at is if your sputum expert is if you get a good sputum sample and the expert is negative, do you have any additional yield from doing the urine expert in that setting? And there's probably minimal yield from doing a second expert. The main benefit is in those patients who are unable to produce a sputum. That's where the real increase in yield that Bianca has shown you. And so that would be the argument, is that essentially from a costing perspective, you're just saying make sure that everybody gets at least one expert and start with a sputum. If they can't produce a sputum, then do a urine. Thanks.
Thanks, Prof. and Bianca. Rebecca, do you no longer have a question? Please keep the comments coming in. Okay, there. Rebecca, you may go ahead.
Hi. It's more of a comment and a follow-on to the issue of LAM reliability. I understand why LAM was made point of care at the clinic level, because obviously there would be a loss to follow up if we had to send a specimen to the NHLS and then await a result. But in the hospitalized context, I think it would be much more logical for the LAMs to be done within the NHLS structure, because it would allow not just for reliability and training and quality assurance, but also a historical record of that result in track care going forward, which often is just not available in the record keeping system. And so I just want to raise that as a point, that could there not be different ways of doing LAM in hospitalized context versus outpatient?
Yeah, so that, has been considered. There was a study done in Khayelitsha a few years ago that I think Graham oversaw, where they looked at whether it makes any clinical impact with the sort of front room healthcare workers doing the test versus it being done in the lab. And there wasn't a difference kind of in, as you would expect, kind of quality control wise, but of healthcare workers reading the test incorrectly or anything along those lines. So that has been answered in at least one setting. There is, of course, the question, which is very important, and I think it lands up getting people in sort of tricky conditions, is the data capturing aspect, like you've mentioned, where a LAM may have been done, for example, at a clinic, and then the patient now arrives at hospital, but yeah, that's not something that I know of that's, as Graham's busy saying, that it's not been, he's motivated for it, but not been adopted. But yeah, has been, I guess, considered.
Thank you, Bianca.
Yeah, I mean, there were discussions probably about 5 years ago now about moving the LAM to the lab setting, the NHLS setting, wherever it was feasible, for the exact reasons that we've discussed. But if I remember correctly, the NHLS didn't feel that there was a test that they were offering, and so it was both from their side and from the provincial side that it had been scaled up as a point of care test, and there wasn't a kind of appetite for moving it into the lab. But I don't think that's something that's necessarily closed forever. I think we need to consider whether that isn't a better place for it to be done where it's feasible. I mean, in a rural setting, maybe it is best to be done at the point of care if people are well trained in using it, and that means a rapid diagnosis. But as you say, Rebecca, if it's in a hospital and it can be done within a few hours in the lab, you just get a much better quality control and a lab record of it, which is important. And I think it's something that we could revisit when motivated for on a provincial level. Previously, it wasn't taken up, but and maybe it's something for some operational research to really look at the problems. Nobody, unfortunately, with these kind of assays, is they're scaled up and nobody really reflects on the performance in the real world enough to see what's happening and what are the problems. And that this might be something that the think tank could take on, a kind of real world study of what's happening with LAM, because I think our sense is that at least in some places there are real problems with its implementation at the point of care.
Thank you so much, Bianca and Prof. We still have just about 8 minutes till the end of our call. If anyone has any comments or any questions that they'd like to ask the presenter. Whilst we wait for that, I'd just like to let people know that if they'd like to see themselves on this very platform, they can email myself at ngosi@tbthinktank.org. I see Panganai's hand. You may go, Panganai.
Okay, thank you very much for the presentation. Mine is a comment, it's not really a question. It has to do with recording of the LAM tests that are done in the facilities. My experience has been that where they use the case identification register, that's where they record all the tests that they have done. Maybe the problem with some places is that they only have one, and it has to move from place to place in terms of all the sites where the entry points. So maybe we can continue to advocate for people to use the case identification register so that we can have a record of what tests have been done and where. Yeah, and the issue of the quality of the is actually critical, because what I have realized is there are facilities that do quite a lot of tests, but never find a positive. And you get a place where the yield is 12%, in some places it's 20%. So you get a spectrum of 0% yield to 25% or 30% in some places. So you really find that maybe there's something wrong with the way the test is being done. It's not being done the same way in these facilities. Thank you.
Thanks, that's very important points.
Thank you. Garang, you may go ahead.
Thanks very much. Graham and Bianca, lovely presentation. It's, so adding my thanks to everyone else. I mean, I think that, Graham, notwithstanding what you said and, the comment that Brent made, as well as the comment that Salome made, that we could be using existing tests more effectively, notwithstanding all the cost factors, is there any data that kind of shows if the test is implemented at scale? Do we have any modeling that kind of shows what the impact on mortality could be? And so, sometimes like putting that data in front of policymakers makes the case more compelling. And I'm wondering, Graham, if there's any opportunity to do that beyond the data you shared on impact of case finding or impact on yield. Thanks.
Bianca, do you want to go?
Sure. The kind of question about whether that data exists is a no, as far as I'm aware. There's no modeling that looks at the impact of urine experts on mortality. I don't know how responsive locally policymakers would be to such results, but hopefully Graham does.
Yeah, I think there was obviously the modeling that was done on the back of Anka Gupta-Wright's study, where they combined both LAM and the first generation urine expert, and showed that it was cost effective. But for urine expert ultra, which has an improved yield, there's been no modeling. I mean, I think if we were to use this observational study data from diagnostic studies, there would be a lot of assumptions that would need to be put in the model. It's not something that couldn't be done, but obviously these modeling studies are much better if it's informed by randomized trial evidence as the kind of starting point of the model, and that's perhaps something that we should consider is a randomized trial of expert ultra, but in terms of developing models from the data that we currently have, I think there would be a lot of assumptions that would go into it, and essentially it's about improved yield and then how more rapidly you can make the diagnosis and what impact that's going to have on mortality, and perhaps you could use the data from the LAM studies to inform that. So it's not impossible, but I think it would be a difficult exercise to do, but certainly something to consider.
Thanks, Graham.
Thank you so much, Dr. Bianca and Prof. Graham again. As I had already mentioned, that if you'd like to see yourself on our platform in the upcoming months, please do email myself at nkosi@tbthinktank.org or anyone else within the TB Think Tank Secretariat. And please do join us in September on the 16th, where we will have Dr. Ethel Velt, who will be speaking on simultaneous initiation of 12-week isoniazid and rifapentine-based TB preventative therapy and dolutegravir-based antiretroviral therapy in treatment-naive people with HIV. And with that said, colleagues, please do enjoy the rest of your day, and thank you so much for joining in on the call. Thank you.
Thanks, everyone.